All right. Good morning, everyone, and welcome to IPF Talks. When we come together and bring you important resources that are in our community to serve you and help you on your journey with Parkinson's or caregiving for someone with Parkinson's. My name is Kim Williams, and I am happy to introduce you to Julia Lowe. She is here with us today from Paradigm Health, and she is going to be talking to us about Parkinson's disease management and palliative and hospice care. And we're super excited to have her with us today and share all the great knowledge and wisdom that she has around this space. And we hope that you'll have some great takeaways today, and we will have some opportunities for questions at the end. But for now, I will let Julia take it away.
Well, thanks, Kim, and hi, everybody. I'm a longtime fan of IPF and the work that they do and the benefits that they bring to Parkinson patients and their families. So I have what's not the most popular topic of conversation in the world, but it is a very necessary topic for people to hear about and learn about because it really affects the quality of life for the Parkinson patient as well as their family. So we're going to talk about palliative care and hospice care and what that means and what it does not mean for those affected by Parkinson's disease. So I'm going to have Addie switch to the next slide. There you go. So palliative care is kind of a lot wrapped up into one big ball of how are we going to deal with the chronic disease that we have and the symptoms that are getting worse or staying the same and we're keeping at bay because we're being active and taking our medications and doing what we're supposed to do. So palliative care is specialized care for people that have a serious or chronic illness, and that is in a little bit more advanced stage. So it's not appropriate for the person who was just diagnosed with Parkinson's disease because we're not quite in that advanced disease progress yet. And we're focusing on quality of life. What can we do every day to help reduce the distressing symptoms? What's disrupting the quality of life? And how can we help that through our team in palliative care? And we can go to the next slide. So palliative care in our palliative care program, it's run by nurse practitioners. So that nurse practitioner becomes like a hub between you and all of your physicians. So that nurse practitioner comes and sees you in your home. Usually it's once a month, more if needed. And they work in conjunction with all of your doctors. So you know how important it is to stay on top of your medications, your treatments, what's going on. Is anything interacting with something? My primary care doctor says this, but my neurologist says that. How do I make sense of it all? And what are they not seeing when I'm coming in the office? So that nurse practitioner spends a good hour with you in your home. So I always say you can't hide what you don't want them to know because they're hanging out with you for an hour in your home and they're going to have updated records from any of your doctor's appointments or hospital visits or anything like that. Um, and they're going to talk with you about them. So they are going to help figure out if you're constantly going to the hospital or constantly having to call your doctor for relief from something, what is that and what's the trigger point and how can we help manage that to improve your quality of life, not only for the patient, but for the family as well. Palliative care has nurse practitioners, licensed clinical social workers, and the social workers are different than if you happen to have a navigator or a nurse liaison. That social worker is there to help relieve the stress, but help support patient and family as well. And that could be through a multitude of resources, anything that you think you might need, but you're not quite sure, they can help investigate for you. They can help with insurance questions and problems. Anything that we're going to do to help walk this journey with you between the nurse practitioner and the social worker, they should be able to wrap that up. It's covered under Medicare Part B or commercial insurance. It does not interfere with any treatment or any therapy. So on palliative care, we're focusing on quality of life, symptom management. What can we do to help you on a day-to-day basis? And it's covered under Medicare Part B or commercial insurance or Medicaid. Okay, ready for the next slide. Hospice care. Wow, is that a scary word or what? Hospice care is a very, very scary word. There are so many misconceptions about hospice. So what I want to say about hospice is put everything that you think you know about hospice in the garbage can, because it's probably not quite right. So hospice is here when you have end-stage Parkinson's disease, when you are needing to focus much more on your comfort than on your treatment. That doesn't mean we stop treatment. So I want to be really clear about that. When we start hospice, we don't stop treatment. We don't stop most medications. We don't stop treatment. We don't give up. Hospice is not giving up. And a lot of people think that that's what it is. So on hospice, we're on the last leg of the journey, but we don't know how long that journey is going to be. Yes, the Medicare definition of hospice is somebody with a life-limiting illness with 6 months of life or less. That being said, the longest I've had someone on hospice is 3 years, and the shortest is less than an hour. I'm going to say everybody's going to fall in between pretty much those time frames. But what we're focusing on hospice is how are we keeping this person comfortable, whatever that looks like for them, and how are we giving them the highest level of care and the most support that we can give in wherever that person calls home. Okay, so we're looking at a journey of comfort and enrichment and making sure that the patient and the whole family is supported in that way. And we can go to the next slide. So hospice care, like I said, patient and whole family, it is a holistic approach to managing symptoms, pain, and stress. It is not just getting medication. It is not just getting equipment. It is not just one thing. It's intentionally focusing on day-to-day life for someone that has very advanced Parkinson's disease or any other very advanced chronic illness. So it's a whole team approach. It starts out with the RN case manager. That RN case manager is what I call your team leader. Okay, so you're going to see that RN case manager anywhere from 2 to 5 times a week. Everything is depending on how the patient is doing. And you could have a bad week this week and see your RN case manager every day. And you could have a much better week next week, and you're only going to see her twice a week. Everything ebbs and flows based on what's going on with the patient. Okay, so you've got your RN case manager, and then you also have on-call nurses 24/7. It's a really important part of hospice care is making sure that we get to you when you need us. So it's not when we need you, it's when you need us. So we have on-call nurses around the clock, At Paradigm, we answer our own phones. We don't use an answering service. So whether you have a question that's keeping you from falling asleep at 2 in the morning, or you're having some type of pain or symptom that you can't get under control, you're going to call us and we're going to start triage right away. And we can send an RN out at any time. After hours, it's not going to be your regular Monday through Friday RN case manager, because we do limit our caseloads and we like to give them some time off. But you're going to get a wonderful nurse who'll be able to come out anytime and help with whatever situation that you are in. We can go to the next slide. So again, part of the hospice care team is the RN case manager. On hospice, we also have an aide. That aide comes out a couple times a week at least for personal care and bathing. So as we are losing some of the control, some of our trunk control, some of our motor skills, we're going to need help to safely bathe, because that's what we want, safe, right? We do not want falls if we can help them. We certainly don't want falls in the shower. So we have an aide that comes out specifically for personal care and bathing. They can change the sheets on your bed. They can make sure that you've got lotion on. They just want to pamper you and take care of you and make sure that you are clean. Also part of the hospice team is the licensed clinical social worker. We have chaplains. Chaplains are non-denominational. They are anything that you need them to be to help with comfort. So they can be spiritual. They can be certain denominational Christians. They know enough about almost every religion or non-religion to help meet the patient on the journey wherever that might be. We also have music therapy on hospice, which is great. So it's an actual clinical discipline. They chart just like a nurse, but you have someone who comes out, usually with a guitar, and plays whatever kind of music you like, but they work on clinical things. So they work on pain control, breathing control, anxiety, clinical things through music. So it's probably like the most enjoyable therapy that you can have, but it's a great part of the hospice care team. And we also have volunteers. So volunteers can do a variety of things, from just being a visitor to helping with something to doing a hobby. It's really, what are you looking for, and do we have that person that we can help match with you? So differences of palliative versus hospice care. Number one, I'm going to say there's a lot of different palliative programs out there. Palliative isn't as regulated as hospice is. It's not as defined. So our palliative is a palliative bridge program. It's focused on symptoms and relief with a serious or chronic life-limiting illness, and you're still receiving active or life-prolonging treatment. So medications are not always a life-prolonging treatment. So on hospice, I'm probably going to say it wrong because I practice all the time. We still take carbidopa. Boy, I hope I got that right. We still take that medication. So life prolonging could be different things. So we always want to check for that. But palliative care, think of as the beginning of quality of life, focusing on symptom relief. Okay. And then we've got hospice care. And hospice care focuses on pain and symptom relief for somebody that is on the last leg of their journey. Usually, like we said, 6 months of life or less, but we are not in charge of when anybody leaves this earth. So I like it when people surprise me and go much longer than 6 months, but they've chosen to stop life prolonging treatment. And that is the big difference between palliative care and hospice care. They both have the same goals: quality of life, comfort, and to stay out of the hospital. They're both focused on pain and symptom relief. Hospice is it gets confusing. It's part of the big palliative care program. So I'm going to say a lot of times, if you have a provider talking to you about palliative care or getting a palliative care consult, you might want to confirm with them what they mean by palliative care. A lot of time in a hospital setting, when they order a palliative care consult, that's really a hospice consult. It's really a goals of care conversation, talking about where you want to be and how do you want to tell the story for the end of your life? How do you want to be in charge of what's going on the last leg of your journey? Okay, next slide, Addie. There you go. So this is just a side-by-side comparison about palliative care and hospice care, because it gets confusing and it gets scary. And this is just the down and dirty about what the difference is. So for palliative care, you need to have a chronic or terminal illness. There are a lot of diseases that people don't view as terminal, but all of us are going to leave this earth at some time. So terminal is just a word. It does not mean tomorrow. On palliative care, you can still have curative or aggressive treatments. You can be pretty much at any stage of the disease. At Paradigm, our palliative program starts once the disease has started progression. We have goals of care and advanced planning conversations. You can have up to 3 disciplines. So nurse practitioner, social worker, and chaplain. Durable medical equipment is not covered under palliative care with Paradigm or with anybody. So that's a big difference. On hospice, we have defined your terminal illness. You're not going to do curative or aggressive treatments anymore for that admitting diagnosis. Usually you have 6 months of life or less. I like to say 6 to 12 because most people surprise me. But we're focused on improving your quality of life and comfort and what's going on that we can help you with the last leg of your journey. Durable medical equipment is covered under hospice care. Eligibility wise, you can get a referral. You can call us and we can get the referral. You can ask your physician, nurse practitioner, anybody, and they can give us the order and the referral. You have to have a chronic illness. Eligibility on hospice, you can self-refer again. You don't have to use your physician. You can use our medical director. And you have a much larger team that gives you that support. Hospice or palliative care is in wherever you call home. So it could be your house that you've been in for the last 30 years. It could be an assisted living, an independent living, skilled nursing, anything like that. Anywhere you call home is where we provide services. Palliative care is covered under Medicare Part B, private insurance, or Medicaid. Hospice is covered under Medicare Part A or Medicaid or private insurance. So you've got lists here. So on palliative care, you really give up nothing, okay? You can have any treatment, see any doctor, do anything in the world you want to do. On hospice care, one of the hardest things for our Parkinson's friends is you have one attending physician, and it's usually either your primary care doctor or our medical director. But we don't continue to see our neurologist on palliative care. On hospice care, I apologize, on hospice care. And that's really hard for a lot of people. That doesn't mean that we stop treating at all. We continue with that treatment plan, and it can change, it can stay the same, but we're focused on the life that we have left right now and not necessarily on finding the new cure. Okay, so hopefully that makes sense. On hospice, you see one doctor, either your primary care or our medical director. And the reason I say that is it's a 50-50 chance. Most primary cares are not following on hospice anymore. And that absolutely does not mean that they are not wonderful physicians. It doesn't mean they don't care or they're not nice people. It just means that hospice isn't their specialty, and they feel more comfortable with our medical director taking that space. Next slide. So you're not ready for palliative care and you're not ready for hospice care. I hear that all the time. And that's okay, because we're here whenever you are ready, but just some things to keep in mind on when you want to schedule a hospice or palliative care consultation, because just like today, if you're listening to me, you're getting information. You're arming yourself with information that you may or may not need in the future. And as you know, it's much better to have that information up front than to try to get that information when you're in a crisis mode. So it's never too early to learn about palliative care and hospice care, because you can keep that information in your back pocket when you need it. And we can go to the next slide. Okay, so signs that it may be time for palliative or hospice care. It's becoming harder to manage pain and symptoms. That's a big one. If we are taking our as needed medication, more like routine medication, or we're having to take it earlier, or we're just not as in control of those things as we have been, that's a sign. If your focus has shifted to comfort over cure. So if we know that we've tried everything that we can try, and we just really want to focus on enjoying the life that we have. If you're going to more frequent doctor's visits, or if you're going back and forth to the hospital, if you've got any increased confusion, when it's taking longer to do bathing or dressing or ambulate, or you're needing more help than you used to, it's okay that it takes you longer to do things. And that is absolutely okay. And we know we're going to end up in that situation, right? If it's taking you longer and it's less safe than it used to, we need to talk. If your appetite is decreased, if it's taking you longer to eat meals, and if you've got progressive weight loss, those are things that are true signs that you need to be thinking about what your next leg of the journey is going to look like. If your mobility is getting worse, even though you're participating in the climb and you're doing everything that you should be doing, there's going to become a point in time when that is going to slow down. That's another sign. Frequent infections or wounds that are not healing. So on hospice, we do wound care and we treat wounds to heal. That's a big misnomer out there. We use antibiotics, we treat wounds. In fact, our case managers do wound care for you, and we try to always heal those wounds. As the body gets weaker, they're not as easy to heal, and sometimes they can't be healed. But our goal is always to heal those wounds. If you're having an increase in sitting time or you're bedbound, if you're sleeping a lot more often, those are all signs that it might be time for palliative or hospice care. So if you're seeing a few of these signs, this is the time to have the conversation. It doesn't mean that it's the time to move forward, but it means that it's time to have the conversation and get your facts, and get those questions answered, because it's really important for you to have a comfort, that you've made the right choice, that you're comfortable with the service that's being provided and with the people that are providing that service. Okay, next slide. Okay, palliative care questions and answers. If you notice, these are the same as the hospice questions. So there's a fine line between palliative care and hospice care sometimes. So same questions, that if you're having these symptoms or these questions in your life, it's time for palliative care or hospice care. And we can help determine what that is, for you and when you're ready for whichever step it is. Okay, next slide. Okay, question and answer time. So who can receive palliative care? As I said, our palliative care program, we call it a palliative bridge program. It's usually somebody that's 12 to 18 months out from hospice, but it also could be somebody that needs hospice tomorrow, or somebody that needs hospice today and they just can't take that step. So we're always going to meet you where you are. We're always going to start where you want to start, so that we can help with quality of life and comfort, whatever stage that you're at. Okay. Um, where can palliative patients receive palliative care? There, again, different programs out there. We're a community-based program. We want to see you in your home. So I'm going to say, if whether you're a caregiver or you are the person being cared for, when you go to the doctor, I'm going to bet most of the time, I call it you fluff and you buff, and you tell the doctor about the best day that you've ever had, right? Because we're human and we don't always want to openly admit trouble that we're having. You know, it's part of it's a pride thing, part of it's we just don't want to admit that we've had a decline. We don't want to say that we need more help than we need. That's human nature. That's very, very common. Okay. I love that we're a community-based palliative care program and community-based hospice care program, that we come to wherever you call home. Because when you're in your own home, we see a much broader picture of what's really going on with you. We are able to see the real picture of how you're getting from point A to point B in your house, the real picture of how long it's taking you to get something accomplished, which, by the way, the end goal is always that you get it accomplished. So if it takes you an hour instead of half an hour, we're good with that. But we see a much better picture in the home, than we would in an outpatient type setting. Okay. Um, can you get therapy and palliative care at the same time? Absolutely, because they're billed under Part B. So you can have any type of home care, OT, PT, speech, anything like that alongside palliative care. In fact, those services usually are very temporary, and palliative care is not temporary. It stays in place. Um, and again, how is it paid for? Medicare, Part B, or private insurance or Medicaid. If you have a copay when you go see a specialist, most likely you're going to have a copay when we come to your home for your appointment. Okay. Next slide. So how does palliative care differ from hospice care? Like I said, the goals are the same: quality of life, comfort, and to stay out of the hospital. So those are goals like I think everybody in the world should have. So good, solid goals. The difference is that on palliative care, you are going to continue with treatments, therapies, anything that you want to continue with. And hospice care, you are not, I'll never say never to anything, but we're not going to continue with therapies usually. Um, and we're not going to continue seeing specialists. We are going to just have one provider. And we're going to really focus on how we're going to keep you comfortable with quality of life, and how to take care of you in your last leg of your journey. So how does it all work? So with palliative care, it is what I call not an immediate service. If you called me today and said you wanted to admit to hospice today, I would get everything moving very, very quickly, and we would admit today or tomorrow for hospice as long as you qualified. Palliative care is not an immediate type service. We're usually about 2 to 3 weeks out for your appointment. So around the same time, like if you would schedule with your neurologist or whomever, the specialty doctors, you don't get a on-demand appointment. But we would get some general information, we would get your medical records, and then the nurse practitioner would come out for your initial goals of care conversation. So that's a pretty long appointment because we're also doing a head-to-toe assessment of you, talking about what's going on with your disease, what's going on with the disease process, what do you need help with, how can we help. It's a pretty involved conversation. It really covers all the bases. Okay, next slide. So, okay, you scared me there. I thought I was seeing too many slides at once. Okay, so hospice care. So we've talked about palliative care. You're still going to get treatment and you're still going to see all of your doctors if you want to. Hospice care. So hospice care is when we are in an advanced disease process and we are ready to really focus on that comfort and quality of life without seeking aggressive treatment. So I hear this all the time, and I hear it from physicians all the time. We're going to stop antibiotics so you can go on hospice. We use antibiotics on hospice. They help benefit for quality of life and comfort. If you have a urinary tract infection, that is not a comfortable thing to have. We're going to use antibiotics for that. Okay, so we talk about it though. It's a collaborative, everything is a collaborative decision between the provider and the patient and family. Okay, so if we think it's a benefit to use an antibiotic for your quality of life and comfort, and you agree, we're going to use an antibiotic for your quality of life and comfort. The big one, nobody wants to talk about hospice because they think if you come on hospice, it's going to hasten death. We are not in charge of when anybody leaves this world. That is not up to the hospice provider. I don't care who the hospice provider is. We're not in charge of when you leave this earth. Okay? What we're in charge of is providing a comfortable, safe environment for patients to focus on the life they have left. In fact, research shows that patients often live longer than on hospice than patients that don't receive hospice. Okay, so if you qualify and you start on hospice, your time to leave this earth is your time to leave this earth, and we're not in charge of it. Okay. Um, oh, I love this. Patients must be homebound to receive hospice. No way. Um, I just left a house today from a lady who was delightful, and she would like to go to Hawaii. Guess what? She can be on hospice and go to Hawaii. In fact, we'll do a travel contract with a hospice company in Hawaii so that if she has any problems, any symptoms, needs a nurse, she can have that while she's on her dream trip to Hawaii. So you do not have to be homebound. You can go do whatever you want to do as long as it's safe. We encourage it. Okay. Next slide. Mhm. Let's see. Parkinson's disease. Oh, okay. See, I told Addie to control the slides today, so I don't have control of him. But let's see if, well, this just talks about Parkinson's disease staging and planning and how we look at that when we support a patient and their family. Addie, let's see if the next slide or if it slides over, if we've got, we'll go back to that one because I want you guys to see the staging. So we'll talk about it in a minute. We'll go through this, some more questions. Oh, hospice is only people who have given up hope. So Parkinson's patients and their families are some of the strongest people that I have ever been around. And there is not a ounce of I'm giving up in any of these people. And that is great because it doesn't mean that you're giving up at all. I hear this a lot from family members. They say, I don't want to talk about hospice because I don't want mom to give up hope, or I don't want my husband to stop trying. Okay. That's not going to change when you come on hospice. We still want someone to try to have the best quality of life they can have. We still want someone to receive treatment and care. In fact, hospice is the highest level of care that you can give someone. So we're not giving up hope. When we come on hospice, we're choosing how we want to tell our story on the last leg of the journey. The other myth, only those who are actively dying qualify for hospice. No, 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 and no. And you're going to see different people in different environments recommending hospice at different times. Sounds confusing? It is. So, generally speaking, people in their own homes come on hospice before someone in a long-term care facility. Okay. There's lots of different reasons for that. Um, Nurses and doctors are fixers. And we like that about them. We like that they're fixers because they fix a lot in this world. They're caring fixers. It's also harder for nurses and doctors to always recognize when it's time to stop fixing and it's time to start focusing on quality and comfort. So when you're in a nursing environment, like a nursing home, generally speaking, they're going to think about hospice a little bit later than somebody in a home environment. Not always, but it's a good rule of thumb to think. So if you have some of the symptoms or signs that we brought up earlier, and you're in an assisted living or you're in a nursing home, you are in charge of your care. And if you want to have a hospice assessment just to find out if you qualify, you can have a hospice assessment to see if you qualify. And you are also always able to select your hospice provider. And they may have preferred providers, they may have their own provider, but you are allowed to choose your own provider when it comes to a hospice company. Um, Do you have to be a do not resuscitate in order to be on hospice? You do not. We have a lot of education on what being a do not resuscitate means, what CPR is actually like, because it's not like what you see on TV or in the movies. But we talk about that. We meet you wherever you are. And we have a lot of collaboration and a lot of discussions. I mean, this is your life or your loved one's life, and we are not here to dictate um, on what you think is the best course of action for yourself or for your loved one. We're here to walk the journey with you and help you, but not dictate. So we do a lot of education on what being a DNR means and what it looks like, but you do not have to be a DNR on hospice. Okay, let's try that next slide. Okay, what is hospice care? That is just a big old long terminology. It's a specialized medical care focused on providing comfort and support to individuals with life-limiting illness. It addresses physical, emotional, social, and spiritual needs. So here's what hospice care really is. It's a huge supportive team that is here to take care of the patient as well as the family as we walk on a journey through end of life. Don't know how long that journey is going to be because we're not in charge of that. We do stay with the patient's family for a little bit over a year after someone has passed. We have bereavement services. It could be a phone call once a month just to see how you're doing. It could be an online support group, an in-person support group. There's lots and lots of different ways that we are here to support after someone passes because we don't know how we're going to react when we grieve. Every grief process is different for every person. Whether you think you've got that under control right now or not, you may or may not. I can't tell you, and you can't tell yourself. So we're here to help that for, a little bit over a year. If you need us longer, that's fine too. How hospice care is funded. Usually it's Medicare Part A. It could be Medicaid. It could be private insurance plan. And we always figure that out before anything starts so that you have a very clear picture of how you're covered. Knowing if you are appropriate for hospice or not appropriate for hospice. It all comes down to medical records and what's going on with you. So how the process works, either for palliative care or hospice care, is we get the referral or we get a phone call from the patient and we start the referral process. We get the medical records, we take a look at the medical records, we run insurance. If we've got questions, we call the different providers, and then we come out and we do an assessment. Sometimes it's very clear on paper in medical records that this person's appropriate for hospice. We still do an assessment. Sometimes it's not clear on paper. We come out and do an assessment and it becomes very clear. So there's a lot that goes into it, but it can happen very quickly if needed. Can I keep my current doctor? That's going to depend on your current doctor. So it would be a primary care doctor. You can always ask your specialist, but I've never had a specialist agree to be an attending before. And most of the time these days, primary care doctors hand it over to us. Again, like I've said before, it is not because they don't care, or it's not because they're not good people, or they don't want what's best for you. It's because hospice is not their specialty. So obviously we're here to support. So besides the patient, the families. So we've got emotional support, resources, guidance, bereavement care, on hospice, we also have respite stays because sometimes that caregiver just needs a break and it's the best thing for the patient and the caregiver. So on the hospice benefit, you have a 5-day respite, 100% paid for in a skilled nursing facility every 30 days. You can use it, you cannot use it. It's there as a safety net in case we need it. Okay, next slide. Okay, this is just a map of everywhere that we serve. And we just opened in Bloomington, and we're up in Fort Wayne and Mishawaka. We cover central Indiana. And that is pretty much our story. We are still a family-owned company. We really have a little bit different philosophy than a lot of companies. So we want to make sure we do the right thing for the right reason. And you can say that, but Paradigm's kind of been known for that in central Indiana and getting to be known for that in our newer territories up north and down south. In your admission packet, you get our CEO's personal cell phone number because sometimes people just feel like they need to talk to somebody at the top. And we want you always to have access to the top. So we're here to work with you. And I am going to, if we can go back and see if we can figure out that slide on with the Parkinson's disease specifics. I don't know if we can or not, and I might just grab my other little laptop here and open it up and see if I can pull that up because I think it's very important. You guys that are listening are affected by Parkinson's disease, whether you're the patient yourself or whether you're the caregiver. And there are things that are very Parkinson's specific. So for Parkinson's disease, early stage, you don't really need us. I mean, you can get our information, but you don't really need us. Once you're in the established range, you're doing the climb, you're maybe doing, I just forgot the name of it, but I want big and loud. There we go. You're doing things that you are helping with your disease process. When you get to the advanced stage for Parkinson's disease, so you're having severe motor skill symptoms, significant gait and balance problems, speech and swallowing difficulties, maybe some mild cognitive impairment. This is saying, I really need to get on the phone. I need to call Julia and I need to get a palliative care consultation set up for myself or my spouse or my mom or my dad or my whoever. Because this is the point when we need to start this advanced care, advanced disease, advanced care. This is where we need to bring in the palliative care specialists so that they're wrapping themselves around you and your providers, making sure that we have done everything that we can do for your symptom management and that we're really taking each piece and focusing on how we can make that quality of life the best that it can be for you. And how does that involve all of your providers together? So advanced disease, you need to start with palliative care. Now, sometimes you look at that advanced disease category and you're like, yeah, I'm there. I'm going to start with palliative care. And we look at your medical records and we say, oh, you can start with palliative care, but I want you to know that you also qualify for hospice care. Okay. Because no person's the same. No individual has exactly the same symptoms, the exact same progress, the exact same anything, because we're all different individuals and different things just are different. So, we may look at your records and say, I know you called us for palliative care, but we think that you really need to be assessed for hospice. And vice versa. You may call us for hospice care, and we're going to say, you know what? You're not quite there yet. Let's talk about palliative care. Okay. So, end stage, what a horrible way to say things, right? End stage, the end. We are all going to be at an end stage somewhere in our life. And I don't say that to make light of it at all. But I'm going to say when we bring people in this world, everybody wants to be around a baby. We want to hug them and kiss them and love them and do everything that we want to do to make them feel how loved they are. Well, that's how I think end stage of life should be. And I don't think we do a very good job of that overall in this country. And when someone is starting the last leg of their journey, I want them to have all the love and all the dignity and all the respect and all the care that they deserve and that their family deserves. So that you can live the last leg of your journey with all of the comfort and quality that we can possibly muster up for you, because we're celebrating the life and the accomplishments and your family and all the things that you've done. We're celebrating that as we're going through the end stage of life. So when you have dysphagia, if you've got some profound cognitive decline, intractable pain, you're incontinent, you're sleeping a lot more, you've got a lot of fatigue, um, you've got weight loss or malnutrition, and frequent infections, that's time for your hospice assessment and to get on hospice services. Okay. So taking all of those pieces and putting them together so that you have the highest level of care, the largest support team, and the most support that you can have. When you're on hospice, under the hospice benefit, it not only covers our services, so the hospice services are in case manager, aide, social worker, chaplain, music therapy, volunteer, also covers durable medical equipment. Pretty much everything except for a lift chair or a power chair is covered under the hospice benefit. And all incontinence supplies are covered under the hospice benefit. And then when we look at medications, there's 3 buckets of medicine when we look at that piece. So bucket number 1 is comfort medicine and anything related to the hospice diagnosis. Okay, that's covered by hospice. And if you're in your own home, it comes directly from the pharmacy that we contract with to your front door. If you're in an assisted living, we're probably going to go through their pharmacy, or skilled nursing through their pharmacy, and it'll get billed to us. Bucket number 2 is the other stuff, I call it, the maintenance medications. So those are medications that high blood pressure medicine or things that you might be taking that aren't related to your Parkinson's diagnosis. And those generally you're going to get just like you're getting now. Bucket number 3 is anything that is deemed curative or aggressive in nature, and those are stopped. Most Parkinson medications are continued. As long as you were able to swallow, we're going to continue those medications. We will always have that conversation with you about your medications. So before you even come on service, you're going to know where all your medications fall in those buckets and how they're covered. Okay. On medications, we as a company, as a Paradigm company, we start with what we call a comfort kit, and it's some emergency medications you're going to keep in your home, or the assisted living or the skilled nursing, and you may or may not need them, but we want those medications that you may need to be available when you need them. So a lot of times, they'll just stay in your home and keep them in your refrigerator. And if we need them, we've got them. And if we don't need them, we don't need them. we don't really care. It's all good. We just want them there. So I kind of got on a little thing about medications. So I'm going to bring up, people are very afraid of morphine. Morphine does not make your life end faster. Morphine can be used for a lot of different things. We use what we call a liquid morphine. It goes into the mouth. It's absorbed in the membranes. It's very effective. Yes, we use it for pain control. We also use it for shortness of breath and some other things. So if you have concerns about medications, you need to let us know, because we're happy to talk with you about what those medications are, what the side effects are, what the benefits are. This is a collaborative team effort between the hospice care team or the palliative care team and the patient and family, because we are going to work with what you need and what you want. Okay? Questions? I can't see if there's any. So, and if you want to
I'm
go
looking
to,
right now. I was just looking right now, and I just one of our participants, Michael, had just said that he you know had testimony to go along with everything you were saying. And I will share, Julia, that my own mother-in-law, when my father-in-law was ill, she said when she got on hospice, she wished she had done it 6 months earlier, because she felt like at that point she was able to be his wife again. She was
yeah,
able to be his caring, loving partner. And before, she was so busy being the caregiver, which
yeah.
there's nothing wrong with that, but she really felt like she really got to be his partner again in his last few days.
And
And so she really, and I told her, I said, Linda, I share that with so many people I know, because so many people
yeah,
wait too long. And I would
yes,
encourage anybody that is listening to this now or going to listen to it recorded, if you're even questioning, call, because it doesn't mean you have to sign up today. Just learn about, hey, this is
right.
my circumstance. What am I most appropriate for? So on and so forth. Because to your point, it just starts a conversation. If it's not necessary now, it's not necessary now, but at least have it planned for, so that you're not in an emergency situation
Yes.
and not able to navigate it well.
Right. Yes. And I will say, I have never ever, I've been with Paradigm about 6 years. I have never had someone say, whoops, oh, sorry, just flipped my little screen. I've never had somebody say, oh, I wish we hadn't done this, but I have heard more often than not, I wish we had done this sooner.
Mhm.
And it is important for people to be able to be that spouse or that child or that special person in their life. That's really, really important. And hospice doesn't provide 24/7 care. We don't do 24/7 care. We're not in the home for hours on end unless for some reason we need it to be. Um, but we help take a lot of that stress off of the caregiver, and we help guide, because when you're that caregiver, half the time you're so busy trying to find the information and making sure you're doing the right thing, and you're researching and you're talking to this person and that person and trying to ensure that you're making the right decision, that you miss that time to be that important person in the patient's life. And so that's very important.
Mhm. And I'm glad that you shared so much of what you did on both sides, because I feel like a lot of people also don't um, make this phone call or start this conversation because of guilt.
Right,
And they don't need to be feeling guilty, because this is not determining anyone's last days at all.
right, right.
This is more of, making sure that they have quality of life for as long as possible, and, are comfortable and at peace on that way. And so I just appreciate the depth that you went into on the Q&A and the myths and debunking those myths, because so many people get things in their heads and they
Right.
feel like that's what they have heard, so that's true. And a lot of times it's not. And so I just truly appreciate you hopping on and sharing all that you know about palliative care and hospice care and the great company that you work for. And it's been wonderful having you on. And I hope that more people will watch this recording and be able to reach out and talk with you or one of your staff and at least learn more about the process. And Julia, how would they contact you in order to do that? Is that something that you can share with us real quick?
Yeah, absolutely. It's on the very last slide, but you guys can call me or text me directly. My number is 317-675-9080. And then our office phone number is there, 317-735-6001. But you can call me or text me anytime. If it's urgent, tell me it's urgent. If you text me on a Sunday afternoon and I've got my phone near me, I'll be happy to have a conversation with you, or I'll let you know that I'll give you a call on Monday or whatever. But um, it's never too soon to start the conversation, and it's so important to be able to get what you need before you're in crisis situation.
Absolutely. Don't wait for an emergency because, yeah, it's much more difficult to navigate that versus
Yes.
having it set to go when it's needed.
Yeah.
So, yeah, thank you again for hopping on with us and helping us to educate those people that we're serving and their care partners. We truly appreciate you, Julia, and Paradigm, and the great community partner that you are with us.
Well, thank you. We love IPF. You guys do a great service, and we're here anytime.
All right. Well, wonderful. Well, we hope everybody has enjoyed this segment and look forward to seeing you next month. And be sure to look for this recording in our next newsletter or on YouTube.